Good morning, dear listeners. My name is Abramyan Arevik Armikovna. Today we are going to talk about frontotemporal dementia. Frontotemporal dementia is a group of neurodegenerative diseases primarily affecting the frontal and anterior temporal lobes of the brain, characterized by progressive behavioral and personality disorders with a gradual loss of empathy and the ability to maintain productive contact. This type of dementia was first described in 1892 by the German neurologist and psychiatrist Arnold Pick. Frontotemporal dementia accounts for 5–7% of dementia cases. The peak incidence occurs at age 55–65, although rare cases of disease onset at 20–40 years and even after 90 years have been described. Etiology of frontotemporal dementia. About 30–50% of cases are familial and are associated with mutations in three genes: the gene encoding microtubule-associated protein tau, the progranulin gene, and the gene encoding the chromosome 9 open reading frame 72 protein. Most often, the disease is inherited in an autosomal dominant manner, so as a rule, careful questioning can identify patients with similar clinical manifestations in each generation. However, sporadic cases of the disease also occur. Risk factors in sporadic cases may include traumatic brain injury, which increases the risk of frontotemporal dementia by 3.3 times, and thyroid disease, which increases the risk of the disease by 2.5 times. No significant clinical differences have been found between familial and sporadic forms or between frontotemporal dementia forms with early and late manifestations. Survival in frontotemporal dementia is about 6–10 years, rarely reaching 12–15 years, and as a rule does not depend on the severity of dementia or the age of disease onset. Classification. The following clinical forms of frontotemporal dementia are distinguished: behavioral form and primary progressive aphasia. Primary progressive aphasia contains primary progressive aphasia without speech fluency decline or semantic form, primary progressive aphasia with speech fluency decline or agrammatic form, and logopenic form of primary progressive aphasia. Behavioral form of frontotemporal dementia. The clinical picture of this form is represented by a combination of behavioral, cognitive, and affective disorders. Due to damage to the basal part of the frontal lobe, social, behavioral, and the patient's personality structure are affected. Main manifestations of the behavioral form of frontotemporal dementia: impulsivity, loss of social inhibitions, including a tendency towards shoplifting, neglect of personal hygiene, inattention, reduced ability to concentrate, inactivity, and mental rigidity. Repetitive and stereotypical behavior. For example, the patient may go to the same place every day. Utilization behavior. Patient may collect and sort random objects with their hands. Approximately half of frontotemporal dementia patients exhibit motor disorders, Parkinsonism syndrome. Primary progressive aphasia syndrome, characterized by progressive speech disorders that arise insidiously without apparent cause and tend to continuously progress in the absence or with minimal clinical presentation of other cognitive impairments. Speech disorders in primary progressive aphasia must be the dominant clinical syndrome for 2 or more years. Agrammatic form of primary progressive aphasia. The agrammatic form of primary progressive aphasia is characterized by the following features: reduced speech rate and speed, frequent hesitations, presence of agrammatism in both spontaneous and written speech, impaired reading and word repetition, paraphasias with substitutions of words similar in sound and structure, reduction in the number of defining words, adjective, adverbs. Speech becomes significantly slowed, monotonous, unemotional, resembling a telegraphic style with a limited vocabulary. Orolingual apraxia is often detected. Inability to click, whistle, lick lips with their tongue. Understanding of words and meanings of objects remains preserved for a long time. Behavioral disturbances may be observed. Semantic form of primary progressive aphasia. Semantic dementia is characterized by the following features: impaired understanding of words, meanings of objects and items, paraphasias, substitutions of words from a single semantic category, for example, television, refrigerator, sun, great sun, etc. The patient does not understand the belonging of words to a certain semantic category. For example, cannot identify the commonality between violet and gladiolus or name the differences between wolf and dog. The patient's speech remains relatively modulated with preserved fluency and speech rate, intonation. The vocabulary decreases with the use of more general concepts, for example, they, things, these, etc. Behavioral disorders similar to the behavioral form of frontotemporal dementia are often detected: impulsivity, tendency to ritualistic behavior, stinginess. Motor disorders are rare. Logopenic form of frontotemporal dementia. The logopenic form of frontotemporal dementia is characterized by the following features: difficulty in word finding in spontaneous speech and during naming, or logopenia, impaired repetition in all phrases and sentences, absence of dysarthria and grammatical speech disorders, preserved receptive component of speech, semantic memory. This form of primary progressive aphasia resembles amnestic aphasia, which is often found in Alzheimer's disease. Diagnostic criteria. Since 1998, frontotemporal dementia diagnosis has been based on clinical criteria proposed by Neira et al. According to these criteria, frontotemporal dementia was diagnosed in the presence of key clinical manifestations: gradual onset and relentless progression, early onset personality and social behavior disorder, emotional indifference, impaired judgment. In this picture, we can see computer tomography of patients with frontotemporal dementia, and we can see atrophy frontal and of our cortex, patient's cortex. Treatment of frontotemporal dementia. The clinical effectiveness of basis anti-dementia therapy and symptomatic therapy for frontotemporal dementia has an extremely low evidence base. More significant emphasis is currently placed on non-pharmacological treatments, which show higher effectiveness. Managing patients with severe behavioral and/or speech function impairment is a complex interdisciplinary problem. In addition to selecting conservative therapy, treatment should include speech therapy training, psychotherapy, and the use of strategies aimed at compensating for lost functions. For frontotemporal dementia patients with affective and behavioral disorders, the prescription of selective serotonin reuptake inhibitors is recommended for their correction. All frontotemporal dementia patients are recommended to receive memantine 20 mg per day as basis anti-dementia therapy. In frontotemporal dementia patients, anticholinesterase agents are not recommended as basic anti-dementia therapy. The using of atypical neuroleptics or antipsycholytics in frontotemporal dementia patients is recommended only for behavioral and psychotic symptoms causing severe distress. For the correction of concomitant Parkinsonian symptoms in patients with frontotemporal dementia, it's recommended to use only levodopa-based drugs at the minimum effective dose. Thank you for attention.